Good morning. Welcome to today's Grand Rounds. It's my great pleasure to introduce Dr. Jamie Boone this morning. And I'm sure most of you know Jamie, but she came to us after doing her APCP residency at the University of Kansas. And then she completed her molecular genetic pathology fellowship last year and then started the Hematopathology Fellowship this year. And that arrangement's really worked out great for me because it's been my privilege now to work with Jamie very closely for almost 2 years now. The other thing that was nice about this arrangement, again, kind of for me, is that it allowed us to pursue a fairly ambitious research project for her molecular year because we knew that she would have a little extra time to finish it after her fellowship year. And that project is now nearing completion, and that's what Jamie's going to talk to you about today, is that project and then kind of some of the background about that. So, again, thank you, Jamie, and it's been great working with you.
I think I'm on. Thank you so much for that introduction. As Dr. Yohi alluded to, the talk that I'm giving today stemmed from a project that we had started early in my molecular fellowship, or specifically intra-tumor heterogeneity and molecular testing in colorectal carcinoma. I have no disclosures. The outline for my talk today, I'm going to start with a very brief background on colorectal carcinoma and then spend a large portion of time talking about the evolution of molecular testing in colorectal carcinoma, including the current recommended guidelines, and then lastly move to discuss intra-tumor genetic heterogeneity and specifics of our project. So with any topic, I really like to start with the big picture, and I feel like for colorectal carcinoma, the big picture is the number of patients that it affects. It is the third most common cancer type among both men and women, and although it's slightly more predominant in African Americans, it affects all ethnicities. The lifetime risk of being affected for any given individual for colorectal carcinoma is approximately 1 in 20. And although over the last 30 years, the incidence and death rate from colorectal carcinoma has been on the decline, it still remains the second leading cause of cancer deaths, second only to lung carcinoma. Additionally, over the last 30 years, the 5-year survival rate has improved for colorectal carcinoma. This largely being due to well-established screening guidelines in the way of colonoscopies, in which patients are being caught earlier in their disease process, as well as better treatment protocols. So with colorectal carcinoma being one of the most common cancer types, it's also one of the most intensely studied, with one of the best depicted stepwise progression models to date. This was first described by Vogelstein back in the late 1980s and has become termed as the chromosomal instability pathway. This pathway begins with mutations in the tumor suppressor gene of APC that leads to dysplastic crypts and early adenomas. And then as time progresses, there's acquirement of additional genetic aberrations that leads to progression and metastatic disease. This pathway really is one of the main pathways for carcinogenesis of colorectal carcinoma. However, there is another pathway that can lead to colorectal carcinoma, that being the microsatellite instability pathway, or defects in the mismatch repair genes. These defects can come about from somatic mutations or epigenetic events such as hypermethylation that in turn leads to microsatellite instability, which we'll discuss a little more in the future slides. So although my talk is really going to focus on the molecular factors in colorectal carcinoma, it's important to note that there are many other variables that are independent prognostic variables for colorectal carcinoma, including the extent of the tumor grade, whether there's lymphovascular invasion, and CEA levels. I also think it's really important to have an understanding of the clinical staging of colorectal carcinoma, as this plays a huge role in what treatments patients receive. With the stage 1 and stage 2 being your more localized disease, stage 3 being your tumors that have regional metastasis in the way of nodal metastasis, and then your stage 4 being your widely metastatic disease. Of note, you still have a large percentage of patients that still present in these later stages of disease. in regards to treatment, it's the stage 1 and stage 2 tumors that are largely treated by resection alone, where stage 3 and stage 4 tumors are the ones that receive adjuvant therapies in addition to their resections. Although there is some controversy with stage 2 disease and whether or not these patients or a subset of these patients should receive adjuvant therapies. And there is one specific molecular finding that we'll discuss later that does play into these stage 2 patients. Also, the 5-year survival rates is drastically different from stage 1 to stage 4, with stage 1 having a 5-year survival rate of approximately 92%, and stage 4 patients having a 5-year survival rate around 10%. So very different from stage 1 to stage 4. And although these different stages help stratify what treatments patients will receive in the way of resection or adjuvant therapy, it's really the biology of the tumors and the molecular findings that help give or guide more specific adjuvant therapies. So moving to molecular testing in colorectal carcinoma, and there's really 2 main areas that we use molecular testing currently for colorectal carcinoma. One being Lynch syndrome, and secondly, that's the identification and screening of Lynch syndrome. And then personalized medicine, specifically in the way of anti-EGFR therapy. So we're going to begin with Lynch syndrome. And Lynch syndrome is due to a defect in the mismatch repair protein complex, which I had alluded to in that first slide, or one of the first slides. And when you get a defect with any one of these 4 major proteins that make up the mismatch repair, I keep wanting to point at the screen that I'm looking at, but so I'm sorry about that. But so the 4 major proteins are the MSH2, the MSH6, the MLH1, and the PMS2. And when you get defects within any one of these 4 protein complexes, you can get mismatch repair, which then in turn leads to replication errors, especially in these simple tandem repeats or repeats of 1 to 6 base pairs, also known as microsatellites. This becomes an issue when these microsatellites fall in important coding genes that then they can lead to frame shift mutations with these mismatch repair or the replication errors, and in turn lead to tumorigenesis. So it's important to realize that although you arrive at the same pathway of microsatellite unstable tumors, there's 2 major mechanisms to get there, and one being in the way of inherited Lynch syndrome, which arises through a germline mutation in one of the mismatch repair genes, and another being a subset of sporadic colorectal carcinomas that end at microsatellite instability through the pathway of MLH1 promoter hypermethylation. Another key finding is the high percentage of these sporadic colorectal carcinomas that are microsatellite unstable that have been found to have a BRAF mutation. The significance of the BRAF mutation in the overall pathogenesis in this pathway is not clearly defined. However, this does become a useful marker in trying to screen out which patients have the inherited Lynch syndrome and which ones are arising through sporadic colorectal carcinoma. And although these 2 tumors, whether you arise through the sporadic pathway or the inherited Lynch syndrome pathway, the biology is still the same. And both groups have a overall good prognosis when they have microsatellite unstable tumors. And then, as I alluded to earlier, there's a subset of stage 2 patients that they debate whether there is a reason for treating with adjuvant therapies. And this is one way to screen, in that the patients that have microsatellite unstable tumors really don't benefit from adjuvant chemotherapy in these stage 2 tumors, as they have no response to the 5-fluorouracil chemotherapy. But there is an important reason to make the distinction whether you're dealing with sporadic or inherited microsatellite unstable tumors, and that is largely for the significance to family members, as these family members of patients with the inherited Lynch syndrome need to be more heavily screened for colorectal carcinomas, as well as the fact that patients with inherited Lynch syndrome may be offered a more or a bigger resection up front due to their inherited disease and the higher prevalence of colorectal carcinoma. There are many different testing modalities that you can use to screen and identify patients with Lynch syndrome. You can look at the microsatellite instability from the contraction and expansion of these microsatellites in a molecular assay. You can look at the mismatch repair system itself through the way of screening with IHC and looking at expression of these different proteins. And then you can use molecular mutation analysis of these mismatch repair genes, and that's used more for confirmatory testing of Lynch syndrome. And then to rule in sporadic colorectal carcinoma, or to rule it out, some helpful assays are the MLH1 promoter hypermethylation assay, which is a molecular assay looking at the methylation status of the MLH1 promoter, and this is currently offered in our lab here. We just went live not too long ago with that. And then secondly, the BRAF mutation analysis. Although there's many different algorithms out there and ways that are proposed to screen for Lynch syndrome, this is one that was proposed by the Association of Molecular Pathology in the Journal of Molecular Diagnostics back in 2012. And what they recommended was doing 3 different testings up front, one being the microsatellite instability testing, one being the IHC looking for the mismatch repair defects, and then lastly the BRAF mutation testing. And with these 3 done up front, they feel that you could accurately classify approximately 94% of patients with new colorectal carcinomas into different categories. The 2 main broad categories are whether or not they have mismatch proficient tumors or mismatch deficient tumors, and that being deciphered from the microsatellite instability assay and the IHC, with the ones that are microsatellite stable with normal mismatch repair expression being in the mismatch repair proficient category, and those with unstable or microsatellite unstable tumors and loss of one of the mismatch repair proteins being in the mismatch repair deficient category. And then further subclassifying these 2 broad categories with the BRAF mutation analysis. With the proficient tumors that are wild type, you've already deemed these as non-Lynch syndrome, but the importance comes in is when they are mutated in BRAF, as BRAF has been found to be a poor prognostic indicator in colorectal carcinoma, and so this further stratifies these patients into a poor prognostic category. Then when dealing with the mismatch repair deficient tumors, looking at the BRAF status, if it is mutated, as I had alluded to previously, the BRAF mutation has not been described in any patients with Lynch syndrome. So this clearly denotes that these patients in the mismatch repair deficient category are of sporadic nature. Then you have to go into additional testing in this category in which you have a mismatch repair deficient tumor that is wild type for BRAF. Then you need to go back to your IHC and look at which mismatch repair protein is abnormal. With the significance falling, if it's MLH1, then you need to do further investigation to figure out if this is a sporadic tumor or an inherited tumor. And you can do that either in the way of the MLH1 promoter hypermethylation assay, or looking at mutational analysis of the mismatch repair genes. So the current recommended guidelines for the screening and confirmation of Lynch syndrome that have been put out there by 2 different professional groups, although there are many others. 2 of the groups that I've highlighted here are the NCCN, and then this collaborative effort between the ASCP, CAP, the Molecular Pathology Association, and then the Clinical Oncology Association. They met back in March in 2015 and drafted these guidelines for the use of molecular testing in colorectal carcinoma. I'll allude to this group a couple of times throughout this talk. These draft guidelines are still preliminary and have not been completely finalized, although they hope to finalize them in the near future. So what you can see for the recommendations of microsatellite instability testing is both groups really, for the most part, recommend it for all colorectal carcinomas. The NCCN, if you read their different guidelines, they have multiple bullet points. One saying all patients with colorectal carcinoma diagnosed at an age less than 70, but then they also go on to say it's needed in all patients with stage 2 disease, which I alluded to the significance of that earlier. And then they have a third comment that says that it should be performed in all patients with advanced colorectal carcinoma. So I think the broad picture here is it's pretty much recommended to use in all patients with a newly diagnosed colorectal carcinoma. The draft guidelines do further say that they recommend the BRAF V600E mutational analysis in conjunction with the MSI and mismatch repair testing up front. So moving on to the next area in which molecular testing is useful in or used in the setting of colorectal carcinoma, specifically anti-EGFR therapy. Anti-EGFR therapy was FDA approved for colorectal carcinoma in 2009. And it's really kind of paved the way for personalized medicine or companion diagnostics in the setting of colorectal carcinoma. And to understand anti-EGFR therapy, you kind of need to have an idea of what exactly EGFR does. And EGFR is a transmembrane receptor that regulates multiple downstream signaling pathways through tyrosine kinase activity. And when there's dysregulation of these pathways, you can end up with tumor genesis through these mechanisms listed here. Colorectal carcinoma is one of the carcinomas that is heavily driven by these different pathways. So with anti-EGFR therapy, you knock out the function of the EGFR receptor, and therefore theoretically would knock out these downstream pathways. I think it's really important to realize that there are two types of anti-EGFR therapy, one being the monoclonal antibodies and one being the small molecule tyrosine kinase inhibitors, with both having different mechanisms of action. The monoclonal antibodies work on the extracellular surface to block out ligand binding, whereas the small molecule tyrosine kinase inhibitors block this tyrosine kinase activity intracellularly. And these two types of drugs and their mechanisms of action are used on two different tumor types. The monoclonal antibodies are used on colorectal carcinoma, and the small molecule tyrosine kinase inhibitors are used on lung carcinoma. And this is due to the inherent biology of these different tumors. As lung carcinoma, a large portion arise from activation mutations in the tyrosine kinase domain of EGFR, and therefore it makes sense that you would want to knock out that function intracellularly. If you knock out the receptor up here, you really still could get activity down here with a activation mutation. And monoclonal antibodies are used for colorectal carcinoma because colorectal carcinoma is highly dependent on this ligand binding. Also of note and of importance is that EGFR mutational status is not predictive in colorectal carcinoma as it is in lung cancer. So we don't test really for the mutational status of EGFR in the selection of patients for anti-EGFR therapy. Also important is downstream mutations can influence the effect on anti-EGFR therapy. And that's why with the FDA approved these two monoclonal antibodies for the use in colorectal carcinoma, they stated it should be used in patients with KRAS wild type status. That being because if you have a mutation leading to constitutive activation within the KRAS gene, it doesn't matter what you're doing up here, you're still going to get activation of this pathway and in turn tumor genesis. So this was really proven from a key study that came out in 2008 in the New England Journal of Medicine, showing that patients with mutated KRAS, the mutated KRAS tumors did no better when they received anti-EGFR therapy than if they just received supportive care alone. So that really defined the status of KRAS being used for the selection of patients getting anti-EGFR therapies. and led to these guidelines in which we currently screen for KRAS status before giving anti-EGFR therapy. So even since 2008, when these guidelines first came out, there's been an evolution in the way we test for KRAS. The original molecular assays testing for KRAS were very specific in that they looked for exon 2 mutations, specifically codon 12 mutations. But as groups such as the Cancer Genome Atlas and other groups that have just done extensive sequencing of different tumors, they have found that KRAS has mutations outside of exon 2 and codon 12 that still affect this response to anti-EGFR therapy. Additionally, they found that KRAS was not the only RAS gene that could affect this pathway. NRAS is also a big player in predicting the response to anti-EGFR therapy. So now the panel keeps growing and growing, and the current draft guidelines that I had alluded to earlier in the talk recommend extended mutational analysis, which includes KRAS and NRAS, and includes exons 2, 3, and 4. And so the problem being is that even with selecting out these patients for anti-EGFR therapy using KRAS status, there's still not an optimal response rate with the patients that have wild-type KRAS status, with some papers quoting a response rate of less than even 20% in these wild-type KRAS patients. And so if you think about it, well, and I'm going to show you a more summarized picture here in a second. This one I just merely show to give you an idea that there's many more players in these signaling pathways than just KRAS. But the ones that they're really focusing on now are the RAF gene, or BRAF, AKT, PTEN, and PIK3C kinase. These are the genes they're looking at to see if maybe they play a role in the selection for anti-EGFR therapy. I mean, intuitively, if you think about it, if you have a mutation in the RAS gene that can cause you to not respond to anti-EGFR therapy, well, mutations in these other genes, wouldn't it make sense that they could also maybe predict response to anti-EGFR therapy? And so there's been a lot of literature to date on this very topic. One specific meta-analysis that came out of Kaiser Permanente group in 2011 looked at these different genes and whether or not they felt they would predict response to anti-EGFR therapy. They felt that BRAF was by far the most promising. However, they didn't feel like it was clear whether or not the response or the poor response they were having to these anti-EGFR therapies was due to the lack of response to the therapy or the fact that the BRAFs are in and itself a poor prognostic factor in colorectal carcinoma. And so there was only one study which they found that compared the outcomes in persons who did and did not receive anti-EGFR therapy with combination chemo, and they found that those with the BRAF mutations had worse survival outcomes regardless of whether or not they received the cetuximab. In regards to PIK3C kinase and the NRAS genes, they found that there was insufficient number of tumors with these mutations to really validate using these genes as anti-EGFR therapy selectors. They just didn't feel like there was enough evidence to date for the use of these genes. And then PTEN and AKT, they found conflicting evidence. There have been more recent meta-analysis since that time, one coming out of the Swedish group in 2014. They looked at a total of 22 studies and really felt that there was enough evidence to date that they felt that it was strong enough to support the use of mutation analysis in these genes to predict anti-EGFR therapy. And so this literature kind of supports why the recommendations are slightly discrepant at this point, with the NCCN guidelines recommending RAS testing, both KRAS and NRAS, as well as BRAF testing. Whereas the draft guidelines at this time only recommend that extended mutational analysis of KRAS and NRAS, but feel there's insufficient evidence to recommend BRAF, PIK3CA, and PTEN testing for the use of selection in anti-EGFR therapies. So what do we offer here in our molecular lab? And currently we offer RAS, we actually test KRAS, NRAS, and the HRAS gene, as well as BRAF and PIK3CA. And as you can see, as I've noted here, we do currently only test exons 2 and 3, but the expansion to the exon 4 mutations is in the near future. Or I don't know about near, but it's in process. Yeah. And so with the guidelines that are out to date, and none of them really recommending PIK3CA at this time, why do we offer this panel to clinicians? And we do give them the option of just selecting single genes for testing, but I think a lot of them actually choose this panel that we offer. And I think it's important because here at the U, we are selecting patients out for clinical trials, and there are many clinical trials that depend on the status of mutations within these different genes, as well as the fact that mutations within these different genes have other significance outside of just the selection for anti-EGFR therapy. So they've alluded to multiple times already in this talk, BRAF is a poor prognostic indicator in and itself, and so has utility in that setting. And although maybe this use is not enough to recommend PIK3CA mutational analysis, I do find it very interesting. This was published in New England Journal of Medicine in 2012. And I think probably a lot of us in med school maybe remember being taught that aspirin helps in the treatment of colorectal carcinoma. But what this study showed is that it's actually the PIK3CA mutated colorectal carcinomas that actually have this favorable response to the use of aspirin. And they think that's due to the COX-2 within the aspirin actually affecting this PIK3CA pathway, or the phosphatidylanosyl pathway, and downregulating it. And that's in turn why it's the PIK3CA mutated cancers that have the good response.
Studies showing aspirin benefit to prevent colorectal cancer are in dispute, and there is no clearly defined. This is post-diagnosis, of course. So
Right, yeah.
As far as I know, the jury's still out about anti-inflammatories and prevention.
Right, yeah, I found that as well.
Mechanisms.
Pardon me?
I was going to say the mechanisms are not
Yeah.
stats or not.
So far I've kind of covered the evolution of molecular medicine in colorectal carcinoma to date, but what's next? And what might be on the horizon for testing of colorectal carcinoma? And I think it would be unfair to talk about molecular testing in colorectal carcinoma without talking about CIMP, or CpG island methylator phenotype, which has even been proposed to be the third mechanism of which colorectal carcinoma arises. The broad definition for CIMP is simultaneous hypermethylation of many CpG islands near the promoter regions of several genes. And it was first identified back in 1999 in the setting of colorectal carcinoma. But over the last decade, this term has really expanded to encompass a broad range of different tumors. And what exactly is CpG island methylation? Well, methylation is an epigenetic event that is one of the best described of the epigenetic events, and the CpG islands are adjacent cytosine and guanine bases, and often they fall near the promoter region of genes. And when they become methylated, it's the cytosine base that actually becomes methylated, and once they become methylated, they cause inactivation or silencing of the genes. This phenomenon does occur in natural processes such as inactivation and imprinting, but in the setting of colorectal carcinoma, it also can lead to tumor genesis. And so the actual significance of CIMP is somewhat controversial, just largely because there's no really great set definitions. There's no great set panel of which genes you should test to call patients as CIMP high, which is what they're terming as tumors that have a large number of CpG islands methylated. And there's no great definition of the number that you need to be categorized into this CIMP high category. So it's hard to compare a lot of the data. However, they have found that there is a large overlap with BRAF mutations as well as microsatellite unstable tumors, and there's a lot less overlap with KRAS mutations. And they tend to have a worse prognosis in comparison to SIMP-low tumors. They've even been proposed as being an independent prognostic marker. However, I don't think we are quite there yet. Other associations that have been made with these SIMP-high tumors are that they are proximal in location, they affect women generally and those of older age, and then histologically they often are associated with mucinous histology and poor differentiation. So then I want to transition to the last portion of my talk, which is intra-tumor heterogeneity. And so I don't think there's one great definition for intra-tumor heterogeneity, but the broad concept is that it's the concept that different tumor cells harbor a different set of mutations or subclones. And it becomes a problem if you do not detect mutations that fall in these small subsets of tumor cells that may affect the response to targeted therapies. And so in a lot of the papers that discuss intra-tumor heterogeneity, they use this branched evolution model. And what it is that you have these mutations or trunk mutations that are the founder mutations. And as the tumor grows and branches, you get these branch mutations that have some characteristics of the founder mutation, but then also develop their own genotype profile. And you could see that it's important to detect all these mutations in your molecular testing is if you miss, say, this subclone with this particular mutation, and it is a mutation that predicts a response to targeted therapies, you may have a failure of these targeted therapies. And so I put this next slide up here, not necessarily to downplay what we're currently doing, but just to highlight the reality of the situation. And that is between 2002 and 2012, 52 targeted medicines were developed. And of those, there was only a median overall survival benefit of 2.1 months. And if you do a cost analysis, this breaks down to a cost of $2.7 million per life year saved. I think this really underscores the fact that cancer evolution and tumor genesis are very complex, and there is a lot that we still need to do to better understand these processes. This paper where I got this quote from, some of the hypotheses for why this is the fact that there is intra-tumor heterogeneity that's been well demonstrated within tumors. In advanced tumors, there's numerous driver mutations that can make targeting therapies towards these tumors very difficult. There's also literature that has shown polygenic drug-resistant mechanisms and subclones even prior to the initiation of therapy. And lastly, you can get these low-frequency subclones that somehow select out and become the dominant mutation or the dominant genetic profile of the advanced tumor. These all make using targeted therapies very difficult. But I want to talk more about intra-tumor genetic heterogeneity, specifically in colorectal carcinoma. It has been a well-demonstrated phenomenon in colorectal carcinoma, and one of the early papers back in 2001 showed a 67% of colorectal tumors showed heterogeneity for at least one genetic alteration. They looked specifically at KRAS, TP53, as well as loss of heterozygosity in the APC and DCC genes, and found 2 to 6 clones per tumor. What was interesting is that they did find that it was more frequent in these loss of heterozygosity alterations than in point mutations. And the point mutations are really what we use clinically. This was a second, more recent study that was done, and what they did is they looked at all tissue blocks within a particular tumor. They tested each one individually and looked to see if there was any discrepancies in focusing on the KRAS and BRAF genes. And what they found was approximately 10% of tumors did display heterogeneity, and if you would have tested those specific blocks within the tumor, you would have missed those key mutations. They also secondarily went on to look at the cases in which there were missed mutations and did a pooled sample to see if that would pick up pooling, meaning they combined all the blocks or tissue from all the blocks and put it together in one sample and tested that, and they did find the mutation that had been omitted from the samples within these cases that displayed heterogeneity. And so this kind of sets the background for the study that we did here. And that is with the demonstration of inter-tumor heterogeneity. Does the location within the tumor affect the results of clinical mutational analysis? I know as a resident that I often wondered, it was often the residents selecting that block for molecular testing, and I often would ask my attending, which one should I choose? And they said, they all had variable answers, and there was never one set answer. And so I thought this study was very pertinent and caught my interest very early on. And then our secondary thought was, and if so, can a pooled sample, as we saw in the previous study, overcome effects of intra-tumor heterogeneity? With our big study aim being to determine the best clinical sample to obtain the highest positivity rate for the detection of all clinically relevant mutations. And secondarily, to identify any evidence of subclonal heterogeneity. So when beginning our study, we used the discrepancy rate of 10% that was found in the literature to do a power calculation to determine the number of samples that we would need if we had 10% discrepancy rate to have statistical power. And we determined that we needed approximately 100 cases, which we collected from the archived blocks from March 2007 and October 2014 that were in this institution. And we had very specific inclusion criteria. We wanted to get tumors that were large enough that we could reliably select out these different locations within the tumor. And those were, we limited the study to excisions. They had to be at least 2.5 centimeters in size, and that we wanted them to be at least tumor stage T3, that being invading past the muscularis propria. And we also excluded any tumors that had previous chemotherapy. So in doing this, we reviewed the slides, and we defined peripheral sections by the normal surrounding mucosa and selected out those tumors that were within a range of 0.5 centimeters of this normal tumor or normal colonic mucosa. Then the superficial portions were selected out, being above the muscularis propria, and the deep sections fell in the muscularis propria or beyond. We picked the superficial and deep sections from the central portion of the tumor, not to overlap with any of the peripheral sections. And then for each sample, we had a pooled sample in which we combined tissue from each of these selected sections. So we wanted this to be a very clinically geared study and have clinical utility. And so we used the clinical workflow that we have in the lab here using the NGS oncology platform and workflow. We, after being selected, the slides were macro dissected based off of those specific location delineations. They then underwent DNA extraction, followed by library preparation, and this was a little bit variable from sample to sample depending on the DNA quantity. If the DNA had a quantity of greater than 15 nanograms per microliter, it was run on our microfluidics chip on the Fluidigm Biomark. But if it had a DNA quantity of less than 15 nanograms per microliter, it was run using PCR on a standard thermocycler. And that becomes important, you'll see in the next slide. Then with either of the on-chip or off-chip assays, it then gets put onto the MiSeq, which is the is an amplicon-based next-generation sequencing platform. And then finally, after being sequenced, went into our proprietary, our local proprietary bioinformatics algorithm, in which we filter out for the chromosomal coordinates of different cosmic hotspots. Cosmic being a somatic mutation database. It's not the best curated, but it is the most comprehensive, and why we selected it to filter out the data. So this is the different genes that we offer based on whether it's the on-chip assay or the off-chip assay. And you can see those that had lower DNA content that went on the off-chip assay did have a slightly more targeted panel, but included all the clinically relevant genes. And so this is the spectrum of the tumors that we had in our study set, with the predominance being of the right colon. We had 46%. They had a large proportion of left colon tumors, and then a handful of transverse colon tumors, rectum, and then we had 5 tumors in which it was not clear where the tumor was originating from the pathology report. As far as differentiation, the mass majority were moderately differentiated, but we still had a large portion of poorly differentiated tumors and a handful of well-differentiated tumors. The average tumor size was 5.8 centimeters with a span of 2.5 to 12.5 centimeters. And tumor cellularity becomes very important in our lab. We want to make sure we have enough tumor cellularity to meet the limit of detection of our assay, which is 5 to 10%. So we need a tumor cellularity of at least 20% to reliably detect mutations. You can see that there are some that borderline on that 20%. However, overall, the average was well above this cutoff. It is of note that the deep had slightly lower tumor cellularity, which kind of makes sense, as often when tumors go deeper, you can get some of those single cells penetrating, which decreases the overall tumor cellularity. So we kept this in mind just going forward to make sure we kept that in mind when we were looking at the different mutations, that we didn't miss anything that fell below our limit of detection. So of our 100 samples, we have currently sequenced 86 samples. 11 are being repeated for various technical reasons, and 3 have failed. Failed being that we couldn't get enough DNA quantity or quality to reliably interpret the assay. We have currently analyzed 80 of the samples, and we have found this mutational profile within our sample set. About a quarter of them didn't show any mutations at all. We did have approximately 28% showing BRAF mutations, which is a little interesting as the literature supports a mutation rate of approximately 10% in colorectal carcinoma, but we have to remember that we did select out for these larger tumors, so maybe this is why we have a higher rate of BRAF mutations within our tumor set. KRAS was the most commonly mutated, which is concordant with what the literature finds as well. Other mutations include a large percentage with PIK3CA mutations, a handful of NRAS mutations, MET mutations, and other mutations, which I'll list on the next slide. So of the BRAF mutations, the majority were the well-characterized V600E, but we did have 2 tumors that showed this mutation at codon 594. What's interesting about this mutation is that it is pathogenic, and experimental evidence has shown it to be oncogenic, but it doesn't respond due to its complex mechanism to BRAF inhibitors. But there is some literature to support the fact that it may respond to more broad spectrum tyrosine kinase inhibitors such as sorafenib. KRAS had very similar findings to the literature, with the most common mutation being found in codon 12, or 73% of the mutations, followed by codons 13 and 61. And the other mutations included 1 mutation in EGFR, 1 in ERB2, and 1 in IDH1. Of the samples that we have analyzed, there was a total of 74 concordant mutations detected, with 8 of those mutations having at least 1 of the 3 samples being detected at subthreshold levels. So when I say subthreshold, I refer to our validated limit of detection in our assay, but we do have the capability of further investigating the raw data in the way the BAM files, and did find that at least 8 of the mutations were present at levels below our validated limit of detection. So therefore not truly discordant or heterogeneous or subclonal populations. We did have 35 discordant calls made, but of note, 91% of those were C to T alterations, which is a well-known artifact with paraffin-embedded tissue. These all occurred at a varying allele frequency of less than 20%. And we did find 3 calls that we feel justify a true discrepant call. for an overall discordance of 3.9% in the non-artifact mutations detected. And what was interesting is all 3 of these discrepant mutations that were detected were in the PIK3CA gene. And this is the profile of these different discrepancies that we found. With sample 1 and 2, focus on those first. Those, interestingly, both had BRAF mutations that was detected in all 3 of the samples. However, they had the superficial and deep both had PIK3CA mutations that were not detected in their peripheral samples. This is interesting as BRAF has been shown, if you go back to the Vogelstein model, to be one of the earlier or trunk mutations of colorectal carcinoma, whereas PIK3CA has been shown in the literature to be a later event. And so it's interesting that it is in the peripheral samples that we're seeing the lack of this mutation, and maybe it suggests that the more invasive or advanced tumor is centrally located. Sample 3, it was also a discrepant call in PIK3CA, although we have to work this one up further. Because the interesting finding is that it was only in the superficial sample, it was not in the peripheral or deep, and I have reviewed the pooled samples for these particular samples here, and it was also not in the pooled sample, which makes us wonder if it was an artifact. It was not a C to T transition, and it was at a varying allele frequency that would make you think it's real. However, we want to repeat it to make sure that this is truly a discordant call. This was another, it wasn't a truly discordant call, but it was very interesting as it shows the same kind of picture as we saw in those 2 discrepant calls, in which we have both an early mutational event being KRAS, and we have a varying allele frequency in the peripheral section of approximately 20%. And the superficial and deep both showed this subthreshold mutation of 2 and 3%, whereas the PIK3CA, a later event in the tumorigenesis, kind of has this opposite phenomenon. So it kind of suggests that superficial and deep, or the more central portions of the tumor, could be the more aggressive or advanced portion of the tumor. And so from that, our preliminary conclusions is that the trunk mutations, being those earlier mutations and the ones that are backed up by high-grade clinical evidence, really were consistent throughout all of our samples that we've interpreted to date. It was these branch mutations in the way of the PIK3CA that may be confined to more invasive or deeply invasive portions of the tumor. So this suggests maybe as clinical pathologists, when we're selecting out these blocks for molecular testing, maybe we should select out a more centrally located and maybe even a deep section. So limitations of our assay include the fact that our assay sensitivity is 5 to 10%, so we're not going to pick up these tiny subclonal populations. However, we wanted this to be clinically relevant, and the assays that are out there for oncologic testing, really, this is a comparable level of detection. Also, we were using paraffin-embedded tissue, which I had already alluded to, the fact that there is this C to T deamination artifact, which makes it difficult, and it kind of is one of the reasons that plays into our assay sensitivity, or probably a big reason that plays into our assay sensitivity, is that it confounds our ability to call low-level variants. And then lastly, we did lose a couple of samples due to insufficient quantity or quality of the DNA, and so that might slightly affect the power of our study. So in summary, the current clinical guidelines recommend testing for RAS and selection of patients for anti-EGFR therapy, with some evidence for the use of BRAF, PIK3CA, and PTEN gene mutation analysis for the selection of anti-EGFR therapy. Intra-tumor heterogeneity may play a role in the failure of response to targeted medicines, and maybe use of invasive or deeper sections in a tumor may be the best sample for clinical molecular testing. So I have many thanks to give, one being to Dr. Furcht for his generous support in this research, from the financial support of the department. Then Erin, Kylene, and Robin in the molecular diagnostics lab, they did a huge amount of work on this project for me, and I'm so grateful. It would have been a lot of time on my part. And then to Dr. Yohe and Dr. Nelson, just for mentoring me and helping me with this project and this presentation, and just for over the last 2 years, just really having an open door and being available for any need I may have. Then I'll leave you with my objectives that I hope I met today. Yeah.
Congratulations on a very good presentation. Tough topics, very clear depiction of the details. The point I was interested in is your discussion of the heterogeneity within the tumor, and probably I was more interested in the superficial portion because from the surgical pathology point of view, we don't have clear guidelines as to whether we submit testing from a biopsy or a resection specimen, and we assume that it is the same, and maybe your work can guide us and guide the endoscopist as well, because as you know, the endoscopist doesn't really want to biopsy the center of the tumor because it's necrotic. They go for the peripheral, and so it is peripheral and superficial. My sense from the data you provided is that probably testing the tumor in the biopsy is going to be representative because superficial was okay, but I'm not sure about the peripheral portion. And then there's another twist to that question about fixation, and I don't know if you tested that because, as you know, the biopsy would be probably fixed under different conditions from the resection. And therefore, I think it would be very interesting if you go back to that same series, retrieve the biopsies, the preoperative biopsies, and run the test on the biopsies and see if it was representative, and then you can make recommendation to surgical pathologists and endoscopists as to whether they should test the biopsy.
Yeah, that's a very good idea to do.
We'll have to wait for the next fellow to do that.
Yeah. Yeah.
So Jamie, going forward, would fresh tissue be a better source of your study's perspective?
Fresh tissue is always preferred in the molecular lab. There is less artifact. The problem being is that it's very hard to come by fresh tissue with these solid tumors.
And then the other component is that we also have to deal with heterogeneity and tumor cellularity. So I mean, you need to develop a careful protocol with our endoscopists, our interventional radiologists, and our gross room, where you're actually, so there is a corneal biopsy device that actually takes two parallel cores. You put one in the formalin, you put one into extraction, and you get to see what you just extracted. Same thing with small biopsies. We need to take polyps, we need to take biopsy samples and basically split them. Because at the end of the day, as Jamie was alluding to, especially with the subthreshold calls, so much of what's critical is actually that morphologic examination of what we believe we put into the assay as well. So that's the only difficult part with solid tumors, and just getting a fresh piece of tissue and blindly throwing it in.
Yeah.
Great talk, Jamie. This week's New England Journal of Medicine has a very comprehensive review of adenomas that might be of interest to you.
Yeah.
A little bit of genetics within the paper. You might check out their discussion of MSI, hypermethylation, see if you find some errors. Write a letter to the New England Journal.
All right.
Get your name out there. But anyway, I think I'll send you the paper.
Oh yeah, thank you. Yeah.
Yeah, just to support what other people have said. It was a great presentation. I have a question on a very basic question.
Okay.
Is there any kind of consensus when you're looking at meta-analysis of response to therapy and saying somebody's responsive or tumor's responsive or not responsive? What that outcome variable, what is the actual measure? Is it an overall survival rate?
They did look at overall survival in the ones that I particularly looked at, but I'm not sure if there's some standard to all of them. I don't know if Andy has a better answer, but sorry.
My understanding, and I haven't read all of them, but a lot of these newer targeted therapy drugs for solid tumors have not shown benefit in overall survival. It's usually in progression-free survival or response rate, and I don't know if there's a standard definition for response rate. I believe that
Yeah, it was this criteria.
I think there are like a certain decrease in size or certain, I think there are standard criteria, I just don't know what they are.
Yeah, it's the RECIST criteria, R-E-C-I-S-T, so it's largely a radiographic. So you'll see waterfall plots with, I think it's, if you have an increase in like 20 points or a decrease in 30 points, that's either progression or regression, and then anything in the middle is considered stable disease. So you'll see a lot of the solid tumor trials use RECIST criteria, which is basically imaging guided criteria to come up with that. And Sophia is absolutely right. I mean, a lot of what these things do is they decrease progression-free survival substantially. The overall survival is generally increased, but not necessarily significantly so. And then that's where a lot of the cost-value proposition becomes important for understanding, is it quality of life that we're actually improving with these expensive therapies, not necessarily quantity of life. And there is an argument to be made there, but it's...
And it's 2.5 months.
Yeah.
Yeah, Dr. Park.
Sometimes less.
So there was a number of
hospitalization
cases where you had sub-threshold amount of mutation in some parts as opposed to others. It's interesting. So how often do you see such situations in the clinic? Because usually it's just one block. And what's your procedure after that? If you detect sub-threshold in one block, do you go to test other blocks?
I would have to. So I was involved in the clinical samples very early on in this NGS platform, and at that time we were looking directly at these BAM files, which you can kind of visualize the different mutations at these clinically relevant hotspots to make sure we weren't missing anything. I don't know what the current protocol is now that they have a lot more automation and filter. Yeah.
I mean, if there's a clinical reason to go chasing different blocks, we go chasing blocks. But usually it's in close collaboration, just like the case that
Yes.
you and I worked on.
No, I'm wondering because maybe the conclusion would be from this study that if you see sub-threshold in one block, maybe there would be a reason to look in another.
Absolutely, absolutely. And so, I mean, that's the thing. So we'll sometimes repeat it to see if it actually, because there is variability. These are not, there's a plus minus 10% in the variance of low frequencies from run to run to run. So we'll repeat it to see if it actually meets criteria, and then also we will try and find secondary samples to verify.
Excellent presentation, Jamie. Did you try to put together a heat map to see the degree of overlap of different mutations in your...
We have not yet, but that is an interesting idea, and maybe we should attempt to do that, yeah.
Yeah. Could you just comment on family member testing? As I recall, Lynch syndrome is only a few percent of that.
It is.
And there it's an autosomal dominant, so really family members really ought to be tested. But do any of these other things, there's no familiarity that you have to, implications on other family members? Is it?
Other than being tested and screened?
Yeah, as a this is a screening for Lynch, I think you're supposed to recommend testing of all family members.
Right.
All siblings and children.
That is correct, yes.
But any of these others, it's not applicable. Okay.
Do you have an opinion on fecal DNA testing that's being promoted heavily throughout the country for colorectal cancer?
What's that again?
Fecal DNA.
Oh, fecal. I did come across that in some of the literature that I was reviewing, but I really didn't delve into that very much.
We don't offer it here, do we?
No.
It's a Mayo test.
Right,
Yeah.
in other places around the country.
Great talk, Jamie. What is the impact of colonoscopy screening on the prevalence and the survival of colorectal cancer?
Well, with colonoscopies, I don't know the actual numbers. I don't know the literature behind the numbers and what studies have been done to specifically look at that. But there has been, that's reflected in our overall 5-year survival rate is these colonoscopies. And when people are following the guidelines and getting the routine colonoscopies, how many adenomas come through our lab? Those are the patients that are being detected earlier and therefore having...
Yeah, well, that makes sense. But is there published literature on that proves that point?
There probably is. I
The challenge now is that we are recognizing a subset of colorectal cancer, the rapidly progressive ones, where you follow those guidelines and you take the polyps out, but still they come in the interval between the colonoscopy with very rapidly progressive advanced colorectal cancer. I thought you were going to talk about that because that's a hot thing.
Oh, yeah. It was a very broad talk already, so I have to kind of focus in.
Yes, and you didn't expand. You had a geography of colorectal cancer, but you didn't expand on whether there were differences between the different areas of the
Left and right.
Left and right cancers.
Yeah. Yeah, we haven't. So our analysis is very. Yeah, it's not.
We still have some samples being repeated.
Yes, we haven't done the full analysis.
Data analysis do you want to do and then have to
It's
repeat?
just a great project.
Yeah,
Great.
on Pat's question on the fecal DNA, I saw a presentation a year ago at the AACR, the Mayo guy who developed the test. And it works really well for left-sided, but it's really not so good for right-sided, more sessile type of tumors. So maybe the shedding from polyps or whatever it is. So that's an area of screening you may miss a lot of it, the right-sided.
Some of the current statistics quote 93% sensitivity.
Yeah.
As high as that, Leo.
I know, but with more than 50,000 and of people.
I'm sorry?
With the data I saw was with more than 50,000 patients screened. I'm not sure it'll get rid of any GI fellowships in medicine.